I'll start. So hello everybody, I am Rachel Winter. I work at the Stonygate Centre for Empathic Healthcare. I'm an Associate Professor in Medical Education and Empathic Healthcare, and I'm also a consultant psychiatrist at Leicestershire Partnership Trust. So I'm talking today about empathy training, thinking more, I guess, about the participant in that training. So this is an overview of what this presentation will be about. I'm going to tell you the headlines, really, about why empathy training is good for patients and what the patient outcomes are. We talk a lot about this at the centre, and it's really important, of course, but I'm also going to talk a little bit why I think maybe we need to focus a little bit more on our healthcare workforce and consider some of the challenges that staff face in training and in working in systems like the NHS, which also might impact our ability to empathise. I'll tell you a little bit about my experience of empathy training at a narrative medicine programme, which was a few years ago now, and how that really got me interested in how training that's aimed to enhance empathy for patients can also have a positive impact on those who are being trained. I'm going to go over the findings of a qualitative synthesis of studies that explore the experience and the impact of empathy training on healthcare students and professionals to show you that you don't have to take my word for it. There's lots of evidence to back up what I'm talking about today. And finally, I'm going to tell you a little bit about our creative empathy team at the Stonygate Centre for Empathic Healthcare and give you an overview of some of the literary arts and creative writing based activities that we're involved in. So there's a lot of focus, and quite rightly so, on the benefits to patients when practitioners are more empathic. We know from some high impact reports, such as the Francis report and the Ockenden report, to name a couple, that there are problems in our healthcare service due to a lack of empathy for patients. We know that as medical and healthcare students move through their education and their training, that empathy does appear to decline. We also know that it's possible to teach clinical empathy and to measure the impact of such training and demonstrate that healthcare students and professionals do have the capacity to learn to be more empathic. And we know, of course, that it's good for patients. So patients who deem their doctors and their nurses to be more empathic have better healthcare outcomes. There are many studies that report that patients treated by empathic clinicians have more satisfaction with their care. They're less anxious and distressed when they're experiencing healthcare. They have better relationships with their doctors. They tend to feel more listened to and more understood. And that, of course, helps them to trust their doctor more and maybe disclose more information to them, which, of course, in turn helps their doctors make more accurate diagnoses. Patients with empathic doctors are more likely to adhere to the treatments that their doctors are proposing or nurses are suggesting, and that might be from taking a medication to making a change in their lifestyle. There's even studies that suggest that patients who rate their doctors as being highly empathic have lower rates of mortality. So empathy is definitely good for patients, but I really think that part of the problem at the moment is that our healthcare staff, the staff that we're trying to train to be more empathic to patients, has very little empathy and compassion for themselves at the moment. I think our staff is really kind of at breaking point. There's been a lot in the news about the problems with our healthcare system. We constantly hear terrible stories of poor, unempathic care. I hear stories from my family and friends. I'm sure any clinicians who are listening would know that feeling of having family and friends tell you how awful it is, how they've had to wait forever to get a GP appointment, how they see a specialist and they don't listen, they don't understand, they don't care. And of course, I've got my own stories, including, I was going to tell you about 3 weeks ago, I took my daughter to A&E. She had a bad landing on her foot in her gymnastics session, and we saw a healthcare professional in A&E, and I felt he did not listen and he did not understand. I told him that Abby, my daughter, doesn't usually complain about pain. She gets bruises and sprains all the time from gymnastics. She's there about 15, 16 hours a week, and sometimes she tries to train on injuries. So she's pretty hardy normally, but this time she did complain. She wouldn't put any weight on her foot. I felt that he didn't really listen to me or to Abby. He looked at her foot and decided that it wasn't fractured as it wasn't swollen or bruised enough. He gave the impression that Abby needed to just kind of get on with it really and expect some pain. And we left without an x-ray. And Abby was quite upset, a little bit tearful, and I felt quite annoyed. And I gave her a hug as we left. And I said, oh, I didn't think he listened to us, did he, Abby? And he wasn't very caring. And Abby nodded and was tearful. But then she added, I think he must have had a bad day, though. He looked really unhappy. And 2 days later, the pain was still bad. So our GP organised an x-ray and her foot is fractured and she's now in a walking boot. So despite being treated by what I felt was a very unempathic clinician who missed the diagnosis, Abby, who's only 12, recognised that there might be something more going on here. There's other factors at play. This healthcare professional might be stressed or tired or feeling fed up with work. And maybe he wasn't just completely incompetent and totally unempathic. Maybe he had had another terrible day working in the NHS. So yes, I think we all have experiences of poor, unempathic care, but we probably have experiences of good, compassionate care too, but we tend not to talk about them. We don't dwell on them. We don't tell others all the time about them, and they definitely don't make good headlines. And as a consultant psychiatrist in the NHS, I know how hard it is. So I know how hard it is when you're trying to navigate the care system with your family anyway. But I also know on the other side what it's like to be a professional in the NHS. There are funding cuts after funding cuts. Our population is aging. There's just increased demand at every level. I work in a memory service. We're a tiny service in Leicester. I think we have about the equivalent of 3 full-time consultants and about 8 nurses, full-time nurses. And we get 80, sometimes 100 referrals a week. We've got about 1,200 people on our waiting list. It's sometimes up to 6 or 8 months to see someone for a dementia assessment. And we know that dementia is one of the most feared diagnoses in people over the age of 65. We really need more staff in our service, as most services do, to meet the demand. But LPT that I work for, like many trusts across the country, have a zero growth policy at the moment. So we're not going to get any more staff. And our list keeps growing. People are waiting longer and longer for an appointment. And of course, by the time we do get to see them, they're even more scared and frustrated. And this really adds to the burden that we as clinicians feel. There's really serious concerns about low morale in primary and secondary care at the moment. There's high dissatisfaction. We're seeing wave after wave of strike action. There's significant workplace stress, compassion fatigue, and frank burnout. So the GMC, I'm not sure if people know the GMC, is the General Medical Council, kind of responsible for regulating doctors. Every year, the GMC run a training survey. So they ask all doctors in training, so a national survey, to complete the survey to try to gain a picture of the experiences of doctors across the UK. This year, about 50,000 trainee doctors, or residency doctors as they're now called, completed the survey. And the findings are really quite shocking. Charlie Massey, who's the chief executive of the GMC, reported profound challenges that remain for healthcare systems across the UK, in particular well-being and its knock-on effects for patient care. So just out of interest, before I kind of tell you the headlines from this survey, I looked up the results to the 2010 training survey, which is the first time that I completed the survey as a foundation year 1 doctor. The words well-being and burnout didn't even appear in the survey. There weren't any questions about well-being. There weren't any concerns, I don't think. This is just 15 years ago. There weren't really any concerns about doctor well-being. They did ask how satisfied doctors were with their training, and about 79% of the 41,000 doctors who completed that survey in 2010 said their experiences were generally good or excellent. It was only in 2019 that questions about wellbeing appeared in the National Training Survey. So these are the kind of main findings, really. 61% of doctors in training at moderate or high risk of burnout. So this is double the number who reported they felt to be at high risk of burnout in 2019. 65%, so most of our doctors feel worn out by the end of the day. 50% say their work is emotionally exhausting to a high or very high degree. 43% say they're exhausted in the morning at the thought of another day at work. 32% say their work frustrates them to a high or very high degree, and 20% feel they seldom or never have enough energy for family and friends in leisure time. And that's actually a really important finding, because obviously, time outside of work, time with family and friends is really protective for burnout and workplace stress. And if we've got a fifth of our workforce feeling they aren't able to enjoy that time or have that time, it's really very challenging. And of course, this isn't just a problem for residency doctors. This is for all doctors and for all of our healthcare system. These are some of the headlines taken from the BBC and from the Times and from the Guardian just this year. They're really quite shocking, I think. I don't think it's a surprise, though. Both these kind of headlines and the findings from the GMC report definitely resonate with me, and when I've been talking to colleagues across different services. A recent study published in the BMJ in September, so very recent, reports that 1 in 3 GPs in England are not currently working in the NHS. There's a massive problem with attrition and dissatisfaction. The study cites previous research that has identified various factors that push GPs to leave the NHS, and these include unsustainable workloads, feeling unsupported and being burnt out. There's been a huge focus on expanding numbers in GP training. I think the training numbers, particularly in GP, have doubled since 2015, but there's really not much, I don't think, being done at the moment to focus on the reasons for attrition and finding ways to reverse that. So from my experience, medicine's still, a really exciting, challenging and rewarding career, but it is absolutely exhausting. It's exhausting working in the NHS. It's mentally taxing. It's emotionally draining. I see poor examples of care on a daily basis, but I also see the vast majority of my colleagues across the NHS in various different roles really just working their socks off trying to get through. It's really hard not to be able to provide the care that you want to provide because of the restrictions that you work under. It's difficult to be told on a daily basis by the public that you, as in the NHS, are failing your patients, that you're cruel and uncaring, that you're overpaid and you're useless. It's also hard, I think, to be told that you're the problem. It's you that needs to be more resilient. It's you as the clinician that need to be more empathic. You need to manage your time better. You need to have a better work-life balance. I think all of these kind of constant messages are, I'm sure, have some truth in them, but can be quite damaging, I think, to our workforce. And the vast majority of healthcare workforce enters the profession to care for others. They are empathic, but the system wears them down. Many do need the kind of empathy training that focuses on their communication and perspective skills, particularly in undergraduate training. But many need training that will also consider their emotional well-being and support them in refocusing on the professional values that took them into medicine in the first place, and really help them to start developing better self-empathy as well as empathy for others. So there's many different types of intervention that we consider to be empathy training. One type of training that I'm particularly interested in and have been for a long time is training that's rooted in the creative arts and specifically in literature. I think that this type of training has potential to foster empathy for patients, but also to support practitioners. So I was going to tell you a little bit about my experiences. So this is an experience with Columbia University. So it's really about literature and about narrative medicine. And there's a really long-standing and meaningful history between literature, creative writing and medicine, which really is rooted in a shared focus on the human condition. So for centuries, narratives have helped people make sense of illness and healing. In ancient traditions, storytelling was part of the therapeutic practice, offering cultural and emotional context to suffering. And of course, in more modern times, the relationships evolved through the field of medical humanities, which really tries to integrate literature, history, philosophy, and the arts to enrich medical education and promote a person-centered care approach. Literature, and in particular stories of illness and recovery, can really foster empathy and insight for patients and help clinicians to engage with patients' lived experiences. So in 2018, I had the opportunity to visit Columbia Medical School in New York to take part in a narrative medicine 3-day course. I went with 2 colleagues. There's a picture of us there. I don't think Hayley will appreciate that picture, but that's Matt and Hayley, who were trainee psychiatrists with me. I'd been tasked with developing and delivering an empathy-focused curriculum for our, at the time, newly established Medicine with Foundation year. There wasn't a huge amount in 2018 going on in terms of empathy training in the UK, but I'd read about narrative medicine and I thought it might offer some insights into how empathy in medical students could be fostered through literature. So Hayley, Matt and I went to New York and took part in this course, and it completely took me out of my comfort zone. So even as a psychiatrist, I've actually got a psychology degree before I went to medical school. I have A-levels in English and theatre studies, and I've got a pre-existing interest in literary arts. But even so, I just felt completely uncomfortable initially and really wasn't sure about this approach. We spent 3 days listening to lectures about art and medicine and learning how close reading of narratives can support diagnostic acumen. We spent time studying paintings to understand how that study could develop perspective taking and empathy. And we spent seminars reading together and completing creative writing exercises and then sharing what we'd written. But despite my initial apprehension, I left the conference, as Matt and Hayley did, with a much better understanding of narrative medicine and some great ideas on how we might embed elements of that type of programme into the foundation year. But far, far more than that, I left the course with this renewed sense of purpose and interest in medicine and in patient care. I was really keen to get back into work, to put into practice what I'd learnt and to continue to work on and develop the tools that I'd started to develop during those 3 days. I really felt that the course had provided this really special space for me to reflect on and learn. And I felt that it was really restorative, I guess, and quite soothing, and definitely gave me this kind of renewed sense of optimism. So a couple of years later, as part of my PhD, I undertook a systematic review of qualitative studies, so a qualitative synthesis of studies that were exploring the experiences of healthcare students and practitioners who had participated in empathy training. I was really interested to find out if others had experienced empathy training, and particularly empathy training in the creative arts, in the same kind of therapeutic way that I had. So from an extensive search, I think of 5 databases, we found 23 studies that met the inclusion criteria. And these studies were investigating various different types of interventions. So from simulation-based and communication-type training to training based in psychotherapy and those rooted in the creative arts. But all had one thing in common, in that they had been designed to foster empathy in participants. So the type of intervention that were described as being based in the arts and literature included, for example, a 2-day intervention where poetry was used to stimulate reflection and support meaning making for nursing students. There was an art making workshop for medical students, a humanities based curriculum linking patient case notes to stories, and an intervention that encouraged students to take part in creative writing, expressive writing and journaling following encounters with patients. And each study was kind of qualitatively reviewed. And so we put all of the findings together, and I used a thematic synthesis to integrate the findings from each individual study, trying to generate a set of analytical themes that allowed new insights from this synthesized data to emerge. And in the end, these were organised into 2 clusters of themes, with each cluster having 2 to 3 main themes, headline themes, and several associated sub-themes. So the first cluster of themes centred around the ability of training to enhance a participant's ability to understand the patient perspective and increase their awareness of patient experiences. There were also themes in this cluster about the ability of empathy to enhance the patient-practitioner relationship, and the realisation in participants that empathy is an intervention or a clinical tool in its own right. And I think that's really very much in keeping with what you might expect to find with empathy-focused training. This training is aiming to enhance understanding and empathy for others, and certainly the findings from this review seem to demonstrate that. But to me, the second cluster of themes is far more interesting. So these are themes that are really focused around improving professionalism, feeling more connected with peers and colleagues, and supporting personal well-being. And these are perhaps less expected. So the interventions didn't necessarily set out to do that. But they kind of, I suppose, these types of themes coming out of the data really resonated with me and my experience of participating in narrative medicine course. These are some of the quotes from some of the studies that were included. And generally, we found that engaging with empathy training was reported to have this restorative effect. The authors of one arts-based intervention reported that it helped participants decrease their sense of personal isolation. Some participants reported that training helped in dealing with other training-related stressors. They also found it helped them develop creativity and imagination. Participants felt that training could provide a safe space to reflect and a haven from their hectic clinical lives and a chance to rekindle past interests, often that they'd put aside when they began devoting so much time to medical training, but then kind of going on past training and into their workplace. And some described it as a real opportunity to start to heal themselves. So it's much harder with interventions that are based in creative arts to estimate exactly how effective they are at fostering empathy for others and improving well-being. In 2020, I published a systematic review of 26 randomized control trials. 22 of these were included in a meta-analysis, and this found a statistically significant increase in empathy. That's my forest plot, when assessed by self-reported empathy measures. And that was for healthcare students and professionals participating in that training. So this analysis, however, grouped together all different types of training. So communication skills training, simulation training, arts and humanity training. So whilst each of those studies were looking at the impact on empathy and were designed to improve empathy in participants, they took very different approaches. So obviously heterogeneity was very high. When individual studies were grouped into different types of intervention for sub-analysis, there was still a significant improvement, a statistically significant improvement in empathy scores, but you can see at the bottom there, the arts and humanities based training, the effect size was smaller. Also that, there's only 2 studies, so it isn't overly helpful. But medics and healthcare professionals and scientists generally like statistics. We like hard evidence that can prove that something's effective or not. And qualitative evidence, unfortunately, is still seen, I think, as somewhat lacking. I suspect if I were to repeat this study now, so 5 years later, I might find more RCTs based in arts and humanities, and this would likely impact these findings. So if we had more studies, we'd get a better idea of what's going on, of how effective they are. But I'm not entirely sure that it's very helpful anyway to do this. It's hard to group all arts and humanities studies together. They're often vastly different. A course in expressive dance designed to foster empathy in medical students is very different from a narrative medicine program for pharmacy students, for example. I'm not convinced either that the scales that we use to measure empathy are really capturing the impact that these creative and humanities types based training have on participants. So if you design a communication skills training session that aims to teach students to better understand the patient perspective and then how to demonstrate that understanding and use empathic behaviours, you'll probably see a difference on a pre-post measure like the Jefferson Scale of Empathy. You're designing a course to enhance cognitive empathy essentially, and you're then using a scale to measure cognitive empathy. If, however, you design a creative arts-based intervention to help students develop a deeper sense of understanding of both themselves and of others, and to recognise and understand their own emotional responses to patients, and to regulate those effectively, and to recognise the emotions of patients and attune themselves to these correctly, you're helping students develop both cognitive and affective empathy. And the scales that we use generally are validated, of course, in healthcare populations, but they don't really capture this quite nuanced side of effective empathy. So I'm going to kind of finish my talk telling you a little bit about the Centre for Empathic Healthcare in terms of creative empathy and what we're doing together as a team. So I work with two colleagues, Dr. Felicity James, who's an Associate Professor of English and Creative Writing at the University of Leicester, and Helen Foster, who's our Creative Writing Associate. So both have vast experience in education and training and are working with the centre to help develop interventions for healthcare students and practitioners that are evidence-based and can support both development of empathy for patients, but can also support participants in developing self-empathy and self-understanding. That are therapeutic experiences for those taking part, can help build into professional connection and reduce professional isolation, and can provide a set of skills or tools that could be taken away and used to enhance personal well-being and professional development. So we're currently also working on 2 systematic reviews. So I've just told you about 2 reviews that I've published previously. These next 2 reviews are going to kind of specifically look at literary arts based interventions. So really try and distill down what we see in creative writing and literary arts interventions. We are going to look at a quantitative review, so looking to see if we can find some statistically significant improvement in empathy. And I've just explained why I don't necessarily think that's helpful, but I think it is part of the evidence and part of the picture. So we are going to try and do that. But we're also looking at a qualitative review, so looking at the experiences of participants taking part in narrative medicine, type and literary arts-based interventions. We're also developing training interventions based in the literary arts for undergraduate medical students at Leicester, including a book club for foundation year students and a writing and reflective workshop for 4th year students, which will be paired with a clinical placement with asylum seekers and people with experience of homelessness. Both of these interventions are being piloted later this year and into next year, and we have quite in-depth research studies set up to look at the impact of both. Felicity also leads on our 3rd and 4th year SSCs. So these are student selected components that all medical students get the chance to take part in. Each week, it's about a 4-week course, and each week of the SSE is focused on understanding a different aspect of empathic healthcare. So students are supported to gain insights into the patient experience, but also thinking about creative practitioners and healthcare workers. They're introduced to a range of reading and writing techniques which help them to respond creatively and reflectively on how these experiences are influencing their understanding of person-centred healthcare. And I've got a very short clip, a couple of minutes, I think, of a couple of the students talking about their experiences, which I thought would be nice to show you. I'm hoping it's going to work.
Hi, Rachel, there isn't any sound for...
Oh. Okay, I don't know why I can hear it.
Sometimes you have to share it and say with sound, I think.
Yeah, I might. Okay, I might. I think these videos are going to be made available on YouTube, I think, and on our website. So I will let you. I'll let you watch them in your own time, hopefully. Okay, so my final bit is just to tell you a little bit about our continuing professional development section. So Helen is our CPD lead, and she's been developing a set of CPD sessions for healthcare practitioners. Helen and Felicity have been involved in running a series of lunchtime seminars earlier this year. So Felicity led 3 sessions thinking about literature and shared reading practices to enhance empathy for patients and ourselves. And over the summer, Helen led a series of online lunchtime activities introducing attendees to some creative writing techniques, really for the beginner's mind, to both enhance empathy and support wellbeing. And these were really well attended, and I think that's really positive. It shows, I think, in our workforce that there is an appetite for this type of intervention. Helen also ran our first face-to-face half-day workshop in September, and we had a range of clinicians and non-clinicians working in healthcare attending. We focused on creative, reflective and expressive writing to foster compassion and insight. And we've just developed and run our first bespoke CPD session and wellbeing session for Leicester Memory Service. And this was really focused both around literature and talking about and discussing the books that might have influenced us, and some close reading exercises of selected texts and poems to foster discussion about patient-centred care, and specifically for the memory service, experience of dementia and dementia care. The morning focused on introducing creative writing techniques that can really deepen awareness and declutter the mind, and build connection with others. And feedback was really, really good. I think all attendees, so it's mostly nurses who attended the session, they were definitely apprehensive. I think they definitely were unsure of what to expect, but they all engaged really well. They enjoyed the session, and they described positive actions that they were planning to take away from the experience, and continue to put into their own daily practice, both personally and professionally. So I will stop talking there. I think I've been talking enough, and take any questions or comments that anyone has. Maybe not.
It was great, thank you. Really fascinating.
Oh, thank you. I do think, I mean, I'm really keen for more interventions to be focused on well-being and burnout. I think it's a real problem with staff, that I think there is awareness of it and we're talking about it, but I think more needs to be done to support practitioners.
Rachel, thank you. That was a fascinating talk. I've just got a question about any longitudinal data that you've got, because you've been discussing the use of empathy in healthcare training, which is great. I'm just wondering what happens when people leave the university environment, go and work in the NHS and experience all the things that you've described to us today. Are you aware of any longitudinal data that supports the use of empathy training in that way?
Yeah, I mean, I think what all the systematic reviews and meta-analyses suggest is that having some kind of spiral approach to training, so keep having doses of training is going to be most effective. Unfortunately, most empathy focused training kind of measure, they take a measure, they do the intervention, they take another measure. Some might do a follow-up measure kind of 6 weeks or even 3 months later. I think in the study of randomized control trials that I did break it down into studies that did kind of immediate follow-up and then 6 months or 12 months. Obviously, I think it was 12 weeks actually and a year. And there's just so few studies that measure kind of sustainability. My kind of hypotheses would be that it doesn't last. So I think that you can't just train. It's like in anything else. You can't just train someone now, expect them, that's it now, they're empathic, because of the system we work in. If we had a better system, we might not need so much training, but most people, I think it's helpful just to have a bit of time and space to be reminded of how to connect with yourself and with others, and to read others' emotions, and to have the emotional support to do that. I think that a lot of the training that we do, both at the centre and when you look at the evidence, is communication and simulation based. And I think that's particularly in an undergraduate setting, that's really important. Certainly cultural differences, I think helping people understand different ways of communicating empathy to different populations is important. But we need to remember that empathy is this kind of dynamic state. It's not just something that you demonstrate, it's a relationship and a two-way street. And we need opportunities to help our clinicians connect with, I suppose, I mean, my theory would be, if we can connect with stories and books and films and the arts in more generally, then we probably are going to have a more empathic workforce because of that, and a more understanding workforce. But then you also need the skills to demonstrate that empathy to others. Does that
Thank
answer
you.
your question? Sorry.
Yeah, absolutely.
Went off on a tangent.
I've got a follow-up question, but I don't want to monopolise your time. So if there are no more questions, I'll come back.
Yeah.
But I just want to wait for other people as well.
Hi, Rachel. Thank you for the insightful talk. I just want to know more about the reflective writing. How does it affect empathy in training? Yeah, I just want to know more about this method.
Yeah. So I mean, I think reflective writing is such a double-edged sword, I think, in medicine. So I can talk about my experience as a trainee doctor and a consultant now, and the role of reflection. And there have certainly been many times when I've found it an absolute tick box chore that I've had to do for each appraisal or each workplace-based assessment. I've had to do reflective writing. But in other times, I've found it really, quite beneficial. It's been an opportunity to really think about a situation, having a bit of protected time. I think for me, often reflective discussion is more helpful, kind of talking things through with someone else and reflecting on things that way with a clinical supervisor, though I'm aware that not every trainee has that opportunity. But I think we can teach reflective writing better, and actually through techniques and creative writing and expressive writing, I think students can better understand the role of reflective writing and how it really can be quite a therapeutic tool for people to use, and also can really help you improve your practice and really engage with lifelong learning. I just think at the moment it's just often used as this kind of, it feels a bit like a punishment almost, or something more as a clinician that you've now got to do. Does that answer your question?
Yeah. Thank you very much.
It's difficult, but it'd be really nice to see reflective writing kind of grouped with creative writing as well, and encouraging people to respond to creative experiences and use those skills that they're developing to then apply to reflective writing, because it is really important. We know reflection is important. Just finding ways to get people engaged with it better. Helen, did you want to?
Sure, I'm back. So my background is as an occupational psychologist, and I've worked with a number of doctors over the years who will say something along the lines of, my joy is found in my clinic. I love working with patients, and then I leave for the end of the day, and then I come back to a million emails seemingly from managers the next day, and they suck my energy. They remove the joy from the craft that I've trained to do. Yeah. I'm just wondering about empathy training, and I'm just sort of making the empathy centres challenge even bigger, is whether you've been exploring and thinking about whether there are other people thinking and exploring about kind of systemic empathic models to avoid that kind of silo of it's the world against me, which can get perpetuated in large organisations.
Yeah, absolutely. And yes, the Stonygate Centre, there is a whole thread on team working and systems-based empathy, and that, I guess that was my kind of alluding at the beginning of the presentation to, you don't often open up the news and read about terrible systems in the NHS and failing IT, that's this, that, the other, or admin burden that's causing these problems. You just read about individual clinicians and how awful they are. And it's absolutely, I'd say, completely honest, it's absolutely soul destroying. Like, all I hear, even from close family who know how hard I work, and you feel that you're taking on the burden of everyone, really, and trying to apologise constantly for the state of things. But it is often the system. The system, I find that people just complain about GPs at the moment. But it's not the GP they're complaining about, it's the system. I can't get an appointment with my GP. I can't use the 8 a.m. system where I have to log on and be in a queue. I can't understand why I have to wait so long. When they actually see their GP, that's fine. But that all just gets mixed into my GP is terrible rather than the system is terrible. So yeah, I think that we really need to focus on the system a lot more, on organisational causes of poor care. And that is working. I know Jeremy and Andy Ward at the centre have done some work where you bring teams together to really try and explore your kind of organisation, because that's the other thing. The organisation is massive and it's different, and people have kind of their local environments within the kind of bigger regions that they work, but the local environment is really important. Yeah, so yes, there's definitely system challenges that prevent empathic working or allowing clinicians to work the way they want to. Obviously, we have to work within systems. That's really important, and they have to be safe systems. And I think most, the burden of admin, which is ridiculous, most of it was brought about for good reasons to improve patient safety, but it's just sometimes feels like it's got out of hand, and it's so repetitive, like just constantly doing the same things again and again. There must be better ways to do this, and I think there often are. One of the things I think that Felicity and Helen and I have been talking a lot about is the role of empathy training particularly in terms of creative training, creative arts and literature, to bring teams together, because I think actually a lot of problems as well is that people feel very isolated. There's a lot of professional isolation. From my own experience, I can cope with most things if I've got a good team, if I feel supported by my team, if I feel, from those little daily connections with people, maybe having a coffee together or having a quick catch up before clinic, to kind of team once a week MDTs where we all get together and someone brings in some cake, and it's just, those are the things that sustain you, I think, in the NHS. But teams are quite fragmented now, particularly post-COVID. Lots of people still working flexibly, which is so beneficial in so many ways, but also has this terrible knock-on effect of separating people and destroying connections. So I think that there's a really important need for team building exercises. But a lot of my kind of experience of team building exercises I found quite uncomfortable, kind of filling in questionnaires about your personality type and thinking about, challenges in the team. Whereas actually I think coming at it from a complete kind of sideline where you're pulling together teams and using books or a poem to really kind of understand each other's perspective and thinking, it just generates these really interesting discussions and getting to know people. When we did it with the memory service, which I'm part of that team, I've worked with some of these nurses for 2 or 3 years and was understanding and learning bits about them that I hadn't realized at all, and starting to think, that's why you're always quite reluctant to do this or that or the other, that's why you're so good at that aspect of care with patients, because of your perspectives on this. So I think that really does have the potential to bring teams together in this slightly new and innovative way.
Yeah, that's amazing. Thank you. You've more than answered my question, and I've got like a gazillion research ideas. So I'll send you an email afterwards. Thank you so much.
I think there's ways to do. If there aren't any more questions, I will let you all get back to the horrendousness of life in the NHS. Thank you very much for listening.